we're talking about like right-sided circulation, hemodynamics, the venous side, not the arterial side, okay? But the arterial side, what happens over there is completely dependent about what's happening on the venous side, because if you don't fill the right side of the heart, the left side of the heart doesn't get filled, right? Okay. So when we are talking about here, though, some stuff comes up about the dangers of over volume resuscitating somebody, and so we'll show you why that's probably the case. So on the y-axis here, this is called a guyton curve. And this is venous return, okay, on the y-axis. And here, this is the right atrial pressures, or the CVP, central venous pressure, okay? And venous return is what is coming into the right ventricle, right, from the right atria. And the right ventricle is going to pump that stuff, and it's going to come into the left ventricle after it goes through the lungs. And so virtually the exact same volume is going to be leaving out of the left ventricle that's coming in through the right ventricle, right? It's a little bit more through the left ventricle if there's no shunts or anything, because some little veins from the bronchioles and some other little cardiac veins will dump into the left atria, left ventricle. But by and large, it's like within a few cc's, right? Okay, so venous return, actually, what do we call it? What do we call the blood per minute that goes out of the left ventricle?
Stroke volume.
Stroke volume. Well, so, okay, so stroke volume, but the total volume per cardiac output, right? So the cardiac output is actually equal, more or less, to the venous return. Okay, does that make sense? So really, we're talking about cardiac output when we're talking about venous return. We're just thinking about this in a little bit different way. We're thinking about things coming in instead of them going out. Okay? So we'll put it at 0 right atrial pressure, okay? And I'll just draw the curve about what happens here. Okay? So at 0, we can't really have a negative central venous pressure for very long. Okay? So at 0 millimeters mercury of a CVP, we run into a limit on how much venous return can happen. Okay? This is called the waterfall area. And so if you think about a stream flowing, and you pick like a stream upstream like a 100 feet, and you go down the stream from that spot, and there's going to be a upstream pressure, and then there's going to be a downstream pressure, right? And so the downstream pressure is going to be kind of backing up the river a little bit, but the upstream pressure is higher, so it's waning in the river flows, right? But if you go downstream far enough where there's a waterfall, there's suddenly no downstream pressure anymore. So that's the point where the downstream pressure no longer inhibits venous return. Okay, and so that's why this comes to a limit, because we can't actually start sucking things when the IVC is already collapsed. This is the point where the IVC is like completely collapsed. Okay, all right. If we draw out this this relationship between venous return and right atrial pressures mathematically, before we do that, let me just show you. So as you see, as the right atrial pressures come up, they get higher and higher and higher and higher. The venous return gets lower and lower and lower. Okay? So someone with a big fat IVC that's got a high central venous pressure, they actually don't have much venous return, right? Because it's inhibiting the flow because those pressures are so high. Okay? So mathematically, we can write this as venous return equals the upstream pressure, which we're going to call the mean systemic pressure, minus the right atrial pressure, the CVP. And that's, and then there's going to be a resistance to the flow because of this, the viscosity of the blood, the how big around the vessels are, things like that. Okay, and so so we'll just call that resistance, venous resistance. Okay, so if we make the point where venous return is 0, okay, at that point we're going to have a right atrial pressure that is going to have to equal the mean systemic pressure, because if the mean systemic pressure was higher than this, there would be some venous return, right? You guys see that?
Mm-hmm.
So at the point of 0, this right atrial pressure equals the mean systemic pressure, so this point right here is the mean systemic pressure. Okay? So to kind of simplify it a little bit beyond what the real truth is, if we stick a catheter in someone's femoral artery, and then their heart stops, okay, the pressure doesn't go to 0. The pressure is like 8 or 9 or 12 or something like that, around that range, okay? That's the pressure settling out from the arterial side and the venous side, and that actually is the mean systemic pressure, okay? So, what makes the mean systemic pressure? It's how much tension there is on the venous system that's the sum total of all of your veins, okay? So about 70% of your blood volume is in the venous side of the capillaries, okay? And only 30% is on the arterial side. And so how much pressure that all that 70% of the volume is mean systemic pressure as a provider of the mean systemic pressure depends on how big or small the total volume of all those veins put together are. Okay, so if we're all vasodilated at any given volume, there's not going to be much tension on those walls. But if we give them a vasopressor, it's going to make all those little arteries tighten up, and the tank's going to get smaller, and so there's going to be more pressure on them. And so that's going to make our mean systemic pressure go up, right? Okay? And because the slope didn't change, we presumably have the same resistance. This is our new curve, if we kept the resistance stable. Okay? Okay, so let me just draw you another picture here that shows you what we're kind of talking about here. And the whole theory about giving fluids. Okay? So here is the right atrial pressure right here. Okay? And here's the IVC. Okay? And here is the vein, the whole sum total of the volume of blood in the venous side. Okay? And so this, from here to here, anything that's not raising pressures above the right atrial pressure is just sitting there. This blood is not going to go anywhere. There's nothing pushing it in. But this volume of blood here, okay, is going to push and drive pressures in. Okay? So this is called a stress volume, and this is called an unstressed volume. Okay? So if we were to not monkey at all, no vasopressors, no nothing, okay, and dump in a bag of crystalloid, okay, we would actually increase this distance a little bit, right? and increase our mean systemic pressure, right? And so we would shift this curve this way, okay? Additionally, and this is kind of getting a little bit nitpicky and stuff, but because we watered down the blood and made the hematocrit go down a little bit, we made the blood less viscous, and so we actually did change the resistance of the slope, because part of what resistance is at. So we actually kind of went a little bit here too, because we've changed the slope. This is the slope, this is the difference between these two, okay? All right, so the other thing we can do, and by the way, if you notice, because we just added fluids here in, we're going to kind of bump up this pressure just a little bit too, right? So the IVC is going to come up a little, right? But hopefully we increase the mean systemic pressure more than we increase the right atrial pressure, okay? Okay. So the other thing we can do is we can add a vasopressor. Okay, and so what that does is we squeeze the tank this way, and so what we did was we squeezed some of this unstressed volume, and because the tank got smaller, it converted it to stress volume, right? We took a big swimming pool, made it a little swimming pool, but kept the volume the same. So some of that unstressed volume got converted to stress volume. And it did the same thing, okay? Now again, getting a little nitpicky, because the size of all the pipes got smaller, that increases the resistance. So our slope gets a little like that. So we don't quite get as much bang for the buck with the vasopressor as we would with crystalloid, okay? But here's the thing, if we're talking sepsis, what we're talking about is a pathophysiologically, no one took fluid out of the person. Maybe someone took a little bit out because they got a fever and they didn't drink a whole bunch for a few hours or whatever. So maybe this sort of stress volume went down a little bit, but really the problem is, because there's all these nasty cytokines and inflammatory stuff going on, is that the tank got really big. And so it converted stress volume into unstressed volume, okay? And so if we take a strategy of filling the tank, when that's not the problem, at some point, we're going to completely fill the tank, but that fluid's got to go somewhere. And where does it go? It becomes interstitial edema, okay? And most of the crystalloid that you give is going to wind up as interstitial edema, okay? And everything upstream from the IVC is going to have an additional pressure stress on it as well, because things start getting backed up as the right atrial pressures go down and the cardiac output goes down, right? So we get kind of, instead of stuff flowing forwards, it flows forwards slower and slower and slower, and the organs will feel the pressure of that backup, because congestion, right? It's the same thing as soaking wet lungs because the left ventricle's failing for the right side of the heart, okay? So like your liver and your kidneys and your gut and all that is the lungs, as far as your, it's the analogies of the lungs for the left ventricle as the, for what is to the right ventricle. So, so the physiologic thing probably is to start early with the vasopressors and not hit them so hard with the fluids, okay? The fluids will kind of fix the problem, but it's a temporary fix, right? And there's consequences to it because things are leaky anyway, okay? So what does the hemodynamics look like as far as what the organs get? Let me hit you with one more thing. So it's a little more complicated than this, but the perfusion pressure of any organ is basically the diastolic blood pressure minus the venous pressure backing up on the other side of the organ. Okay, so this is basically mainly affected by venous congestion. What's your CVP? The higher the CVP, the lower the perfusion to the organ is. Okay? So the reason why a CVP is bad is it's a couple of things. One is that it actually, the higher it goes, the more it decreases the venous return. Okay? The second thing is that it actually decreases the perfusion to the organs, right? Okay. So, what is the pressures, what's going on with the right ventricle and the way the pressures are all going from, let's take it from the right atria, okay? From the right atria going backwards, and what's the pressure sort of look like? Well, we got a baseline pressure here, and let's take the cardiac cycle. So we got a P wave, we got a QRS, and then we got a T wave, which is repolarization, right? And then we get another P wave, and the cycle starts again, right? So if you probably learned this in nursing school, right? But the JVD, right? And we can look at the JVD and see what the right ventricle and the right atria is up to, and what's going on with the central venous pressure or the right atrial pressures. So there's no valve between the right atria and the vena cava, right? So when that atria contracts, a lot of the blood is going to go backwards, right? And so what happens is we get a wave that looks like this in the jugular vein if we're looking, okay? And then what happens is we enter systole, okay? So two things happen hemodynamically as far as the venous return happens during systole. The first thing is that the right atria relaxes, and so it sucks blood in, right? So we get a decrease in pressure of the JVD as blood's going into the heart. And so we get a little bump here, and the valve closes, there's a little C wave here. This is called the main wave, okay? We get a little bump where the tricuspid valve actually closes when the onset of systole while this is relaxing. And so this is atrial relaxation, but when the right ventricle contracts, remember the right ventricle contracts like this, and the left ventricle rings like this, right? So as the right ventricle comes up, it actually kind of pulls some blood up with it too, okay? And so we get this downward pressure wave, okay? And this is called the X descent. If you remember this stuff, this sounded familiar? And then, because the right atria starts to fill, the pressures start to slowly rise, okay? And then what happens at the onset of diastole is suddenly the tricuspid valve pops open because the pressures inside the right ventricle became less than the pressures in the right atria. And we get a second descent, okay, which is the Y descent, okay? And then as the ventricle fills and fills and fills and fills, the pressures go up and up and up, kind of slowly backing up, and then we start the cycle over again with atrial contraction. So this is diastole stuff happening, okay? Diastole, systole, okay? So what we have is as far as the jugular vein is concerned, and pressure and flows and everything, is during systole we have an initial gush of blood, of venous return into the right towards the right ventricle, and then in diastole we have a second gush, and then we have like a little reversal gush with atrial contraction, okay? And what happens is, as the right atrial pressures go up and up and up, there's inhibition of venous return. okay? And so this wave will kind of get smaller and smaller and smaller compared to this one. And this wave, as pressures go up, will get hot. There'll be more and more reflux back because we're getting congestion. Things want to go backwards more than forwards to a greater extent, okay? Hopefully things are still on, going forward a little, right? Else we're dead, okay? But that is kind of the physiology that I think you all probably learned in nursing school at some point, right? For a test. And then you didn't see the relevance, and so you didn't keep up with it in your brains, right? But in this case, this stuff is relevant, okay? Maybe not like exactly what the waves are, but if you're gonna be looking at hepatic vein Doppler, which I hope will get you to, or understand what's happening with portal vein Doppler or renal Doppler or any of this stuff, it all comes down to this, and it all comes down to this stuff here. Okay, so we got the IVC. We usually aren't Doppler in the IVC, we're just looking at the IVC, right? So an IVC that's big and fat and not collapsing is here-ish, okay? And a completely flat, never opening up except for little blips like this, with respirations, is here, okay? So this person needs either fluids or a vasopressor, right? And this person here needs some diuresis, okay? People try and look at the IVC and guess what's going to happen with the left ventricle, okay? So I think this is the wrong approach. In other words, people will look at this and see, can I predict volume responsiveness, okay? So I think if you're here, it's almost 100% you're going to be volume responsive. And if you're here, it's almost 100% that you're not going to be volume responsive. But what's happening here and where that is, it gets hazy, okay? So I think if you're at one extreme or the other, you can make an educated guess on what's going to happen with giving fluids or giving a pressor or whatever. But if someone tells you it's between a CVP of like 4 and 5 that they're going to be volume responsive, they don't know what they're talking about, okay? They absolutely don't know what they're talking about. And the reason why is because they don't know how stiff the right ventricle is and how compliant it is, because that's also going to affect the CVPs, okay? And it's been proven that CVPs and thus the IVCs, because it's just a reflection of what's going on with that circulation, it does not predict any better than flipping a coin whether someone is volume responsive, okay? Except maybe at the extremes. But we're talking about the middle ground because most of our patients are here in the middle ground, okay? So really, what we're kind of talking about when we're looking at an IVC, I think, is not volume responsiveness, because if we wanted to really do that, we need to go to the left ventricle and interrogate what's happening at the LVOT with the volume challenge, okay? That's the best way to predict that. But there's too much in the way here, and to really predict, I think with a reasonable amount of certainty, if we should be giving fluids or not. However, if we're heading over towards a plethoric IVC, these are high right atrial pressures, and these are low venous return states that are only going to get worse when we throw more fluids at them, okay? So we should be talking about with the IVC, I think, volume tolerance. In other words, can we give some more fluid and get away with it, hoping that it causes an increase in venous return and cardiac output, okay? Or is the IVC telling me, hey, back off, okay? Because what's going to happen is it's going to ultimately decrease the venous return, and it's going to also ding the perfusion of our organs, okay? So, everyone with me still? Okay. So the IVC, we talked about that, and then let's talk about what the theory behind what's going on with the hepatic vein and the portal vein and the intrarenal venous Doppler. Okay. So here's our baseline on our Doppler here. Okay. And so let's say we drop the pulse wave Doppler right on the hepatic vein. Okay. And what we're going to see is we're going to see the exact mirror image of this right here. Okay. Sorry, we're going to see the exact same thing going on as we have here, because what happens is that as the right atria contracts, it is going to reflux blood up, right? And because here's our IVC, here's our right atria, we drop our gate here, so the right atria contracts, blood comes up that way because there's no valve. So we get this, and it's called an A wave, okay? And then we have the right atrial relaxation and the right ventricular contraction, and we get a wave like this that we don't call an X descent anymore. We call it, more logically, an S wave. Okay? Sometimes you will see two blips of the S wave, and the first blip is actually called S1, and the second one is S2. And what that is actually the atrial relaxation component and the right ventricular contraction component. So atrial relaxation, ventricular contraction. And then this will return nearly to baseline, maybe go over just a little bit, and then you get this wave, which is the Y descent, and we more logically call this the D wave because it's early diastole. Okay? And just like the X descent pressure drops, get less and less and less as the right atrial pressures go up, this will get smaller and smaller and smaller relative to D, and this will get bigger and bigger and bigger relative to where it started at. It'll get wider and it'll get higher velocities because it's more backward flow. Okay? So remember, this is like a velocity time integral, right? So the area under the curve actually equals total distance traveled, right? Rate times time equals distance. And if we have a cross-sectional area, we can say it's a volume, right? Okay, so as the pressures go up, this gets bigger, lasts longer, this gets smaller, and this stays about the same. Okay? And eventually what happens is this actually reverses, kind of blurs here, and we get like a kind of a biphasic sort of looking thing. Okay? And if you put a color Doppler over someone with high right atrial pressures, because red is to the transducer and blue is away, you'll go blue, red, blue, red, blue, red if you have really high pressures. Okay? So that's like a quick and easy way without dropping a pulse wave Doppler, which can be hard. You just put the color box over here. And if it goes blue, red, blue, red, blue, red, that's high right atrial pressures. You're already going to have a hint because your IVC is going to be big and fat anyway, but you know that it's getting transmitted backwards up into the liver when you see that blue-red alternating pattern. Okay? Okay, so the liver, there's the hepatic veins back up, and they go into like some sinusoids, right? Where, like to go the other way, is that the portal veins are draining the intestines and the visceral organs and all this stuff, right? The spleen, stuff like that. And they come into the liver, and they branch into smaller and smaller little portal veins until they hit the hepatic sinusoids. And then they trickle through the sinusoids, and there'll be, remember your anatomy here where you have kind of like the portal triads, right? And you have like this kind of hexagonal thing, and the sinusoids are here. And then in the center you have a central hepatic vein. Remember that from histology? And so you go from a portal vein through the sinusoids into the hepatic vein, and the hepatic veins join up until you have just 3 of them, and those dump into the IVC. Right? Okay. So if our pressures backing up into the hepatic veins up through these sinusoids get high enough, it's actually going to kind of press and push back through the portal system. Okay? And the portal pressures are going to start getting high. Okay? And we can Doppler the portal vein and see that. And when we see that, if our portal pressures are high, that means that our gut pressures are high because the venous pressures of the gut are high, and our gut's getting kind of ischemic and puffy. And it gets
leaky.
And leaky. and it gets pissed off, and it sets loose some cytokines that are all the sepsis cytokines, and that makes our sepsis worse. So if we see a pulsatile portal vein in someone with a big fat IVC and a blue-red hepatic vein, that person probably has gut edema, and there's some inflammation getting released that's just going to make things worse. The other thing is bacteria can get translocated and wind up with bacteremia too from puffy guts too. So what does a portal vein look like? So the portal vein normally will have a nice kind of above the baseline sort of hum, okay? And if you get your Doppler angles just right, it's about 20 centimeters per second, okay? And you'll know that if the portal vein is venous flow is going to the liver, and you put the color box on it, it's going to be primarily just a red thing going towards it, okay, if you've got your probe in the right position. Okay, as things get more and more pressure loaded, your portal hypertension happens, it starts to get pulsatile. It's that red blue thing happening, okay? And we start to see bad things happen when this amount of pulsativity gets higher than, say, like 30%. Okay? And as this gets worse and worse and worse, it actually becomes biphasic. And then ultimately, with bad portal hypertension, it goes away from the liver into the gut. This is your cirrhotics here and here. Because the portal pressures are so high. It's just the liver just like oozes juice into the peritoneal cavity. Okay? Okay. And then real quick, as far as the renal stuff goes, the baselines like this. Don't pay attention to this, but there is going to be a systolic and diastolic arterial component of when we Doppler the kidneys. But but you're Doppling the arteries and the veins in the kidney at the same time with the same pulse wave gate, and so we will see this like kind of hum, just like we would with a normal portal vein happening in the venous side. And then as the pressures get higher, it starts to get pulsatile. Okay? And then as the pressures get higher, we see something really interesting happening. We see a biphasic pattern. One corresponds to systole and one corresponds to diastole. And these are these. This is the systolic one, that's the diastolic one. We don't see the A waves on it. Okay? But just like what happens with our central venous pressure waves, as the pressures go up and up and up, this one will get smaller relative to that one, and then it just disappears. Okay? So this is a very extremely congested kidney with very little perfusion. This is a kidney also, it's just not as bad. Okay? All right. So, all right. So I think this is really hard to do. So you have to practice a lot and stuff. So we're going to leave that alone. And I think that the hepatic vein, we probably can leave that alone just because, if you put the color box over it, that's probably okay, good enough. To try and put the pulse wave Doppler, I think unless you're really good, the patient's moving, they're breathing, things are moving around, and it might be hard to get a hepatic vein Doppler waveform on that. The reason I do it is actually you can calculate what the right atrial pressures are pretty accurately by taking the ratio of this to the sum of this divided by the sum of these two. velocity time intervals or actually peak velocities too, and plug it into a formula and you get right atrial pressure at the other end. But really all you really care about is if it's high or low or what. Okay, so how do we do it? Usually, as far as the portal vein goes, you guys all know the IVC. We're going to start here, kind of trying to find a portal vein, move the probes a lot of times over here is where it's at, and what you're going to see is, you'll see the portal veins come in, you'll usually see a vessel like this, and it'll be kind of a bigger one, okay? And if you drop the pulse wave Doppler in the middle of that, then you'll get this hopefully, okay? So you don't want to confuse it for hepatic vein. And what's the hepatic vein going to look like? Again, it's going to look like this, right? What about a hepatic artery? What's a hepatic artery? Because it's going to be in the same neighborhood as the portal vein too.
Blue, red, blue, red, blue, red.
Well, this will be blue, red. Actually, yes, it'll happen is it'll flash red, 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 and if it's aliasing because you exceeded your Nyquist limit, you'll be red and like be flashing blue in the middle. Okay, I think you guys seen that, right? And if you don't know what I mean by Nyquist limit and aliasing, don't worry. But you'll see this. Okay, it'll look just like the arterial stuff going on with that. Okay, so if you drop your pulse wave Doppler and you see a triphasic or a triphasic pattern, or you see an arterial pattern, you're on the wrong vessel. Now the thing is that the hepatic veins usually don't go with the portal veins, but the hepatic arteries do. Okay, and so it might be, if this was like a biphasic pattern, like sometimes happens with the hepatic vein, you're not going to usually get that too confused with the portal vein because it's nowhere near it, and the vessels are different sizes, and the portal vein is wrapped in peritoneum sort of type tissue, so it has a bright wall, and hepatic veins, you can't see the walls, okay? So it'd be a little bit more difficult to confuse those. Okay, so problems with the IVC measurement. I, by and large, don't see it too often, but everyone needs to kind of be aware of it. We kind of told you the real kind of specific place to look for it is what's happening around here. And the reason why we told you that is because that's what the American Society of Echocardiography says you should measure, and that's also where all the researchers are measuring, just for the sake of consistency. But if you guys have seen, I hope, enough IVCs that you know that what's happening here looks a lot different sometimes than what's happening here, right? So we really should maybe not be doing these collapsibility indexes, which we're doing, and I think we'll still kind of do it. But if you guys see the IVC, and it's not really collapsing much here with respiration, but everywhere else it is, then this is probably not telling you the real story, okay? You got to kind of look at the whole IVC.
Could, if you have high right atrial pressures, would that collapse less there at the point of entry if the IVC was truly empty, where it would collapse more a little further back in your other part?
What's happening is really complicated. You actually have intra-abdominal pressures that are affecting it, interthoracic pressures maybe pulling it in at certain respiratory phases, and then you've got the cardiac cycle dealing with it as well. Okay. And so you really kind of, a lot of times, have this undulating thing that's doing all things, and you just got to kind of see enough of these things to like get a good gestalt about what's going on. And I think that maybe most of you kind of are sort of at the point where you're just sort of catching on to that you've seen, like 500 of these things, and now you're like, it's not that, but it looks empty to me, I've heard you guys say that, even though it doesn't look like it's collapsing where we're measuring it, right? So yeah, and another thing is sometimes the diaphragm's here is sort of like splinting things open, and that's going on. The other thing that you got to watch out for, and so probably it's better to look at the IVC in two dimensions, and then when you're in this cross-sectional dimension, slide it back and forth along the length of a few centimeters of the thing. Okay, so up here it's going to look like this as the 3 hepatic veins come in. Okay, and then anywhere else is just going to be a circle. But it can look like this. Okay, it can look like this, right? The anatomy can be kind of funny on the thing. And the other thing is that if you drop your M-mode beam, when you're doing this, and you happen to be dropping it here, the IVC is going to look smaller than if you dropped it here. And you actually, by accidentally fanning back and forth and not holding your hand steady, be fanning it here and then back to here and then back to here and making fake collapsibility, right? Because we got it here and here, and that's like 50% collapsibility, right? Just by wiggling it like a half a centimeter back and forth. And it even gets worse if you do it here, right? And here, right? So if there's high pressures, it should look more round. And if the pressures are, the right atrial pressures are lower, it's going to be more collapsed and more oval. Okay, but if you looked at this IVC, which if I showed you an IVC that looked like this in cross section, you would say that the right atrial pressures are low, right? But then if I showed you it in long section, you'd say, ooh, right atrial pressures are high, right? So the only way to do it is to quickly flip 90 degrees, look, slide it down, see what's going on, okay, with that. And then you really should pay attention to centering this and not fan back and forth when you're measuring the IVC. So those are the things to watch out for that. Okay, we covered portal vein, right? Okay, so then let's do some scanning. Any questions?
How about if we can't see the IVC anteriorly and for some reason?
You can come around this way and look. It's okay. You're going to get a little bit more of this stuff going on that way. If you got someone who's got cirrhosis or whatever, it's going to be really hard to use the liver as a window because the sound waves are going to get attenuated before it gets there. But I'm sure all of you, when you're looking around, you've come around this way, and you can see sometimes the aorta clear on the other side of the liver, right? Because you can use it as a window. But the IVC is going to be there, okay? And if it looks like it's doing a lot of this, your right atrial pressures are probably lower, and you're probably still volume tolerant. And if it looks like this and not moving at all, so you can do workarounds. Like, it's best to look at it this way, but just because gravity is going to be, it's more likely to show up like this than that, right? Right. So here, here's your kind of home base here, your IVC area right there, right? And you guys.
Do you like using that one?
You can use either probe. But this is a portal vein right here, okay? You see it? And if we put color Doppler over, it should be mostly red, which it is, right? And if we can kind of follow around this way too if we wanted to. And that's his gallbladder. Okay, right there is this portal vein here, okay? So we get a better Doppler angle if we come around to the side, usually. This is a hepatic vein here.
So you said you can tell the portal veins because of the hypercoagulability.
Yeah, see how bright it is around it?
Oh, yeah.
And then here's a hepatic vein. See the walls? You can't see the walls. And here's a portal vein. You can see the walls. Okay. Now the hepatic artery will look like that, though. Okay. But
darn it.
But let's.
Will the hepatic artery be visibly pulsatile for your image or no?
Yeah, it can be. Okay, so let's just do this one because I'm getting a good Doppler angle. But you may have to come. What I'm saying is you might have to kind of come around here and try and get a, try and work a better Doppler angle. But the more up and down you can get it, the better. And he's got a pretty up and down one here. And just put the color box on. There it is. Hold your breath for a second. And you drop a pulse wave Doppler right through the one going up and down. Okay? And so you can see he's got a nice phasic, it's not pulsatile thing going on, right? And if you want to kind of make it a little bit more dramatic, you can put the pulse wave Doppler on, and you can mess around with your your scale. Back on the portal vein. And we kind of lose some of the density of it, but you could see more pulsatility if it was there, which it's not. Okay, but let's go back to. Okay, that's the artery. And the artery travels right next to the portal vein. Okay, so if you see that, you're on the wrong vessel. Okay.
Are you on both of them right there, or just that?
Yeah, we're on both. We're getting crosstalk between both vessels. Yeah, so this is the portal, the bright one down here, and then this is the artery. And what's happening is both of them are inside the gate. That's the vein. So there's the central hepatic vein. If we had him hooked up to the EKG, we could show you better, but show you with the cardiac cycles, right? But this is the S wave, this is the D wave, and this is the A wave. Okay, and this will be variable in people, so you can't really get. It's best to have an EKG tracing on that. But notice that his S wave is quite a bit taller than his D wave, right? And this is kind of a little bit baby A wave, right? So his right atrial pressures are very normal, okay? So, but this is a triphasic one, down, down, up, down, down, up, down, down, up, down, down, up, triphasic hepatic vein pattern, okay? This is way different than a portal vein, right? Yeah, like that.
Okay, what was
And
that?
just fan right there, and fan back so it's one big vessel. Hit the color, and then with your left hand hit the PW. Put it on that.
So yeah, that's just all.
And hit it again.
So,
Good.
So
And the artery's just faintly behind it.
central,
Okay? Below the baseline. So take your probe and just kind of fan it to one side or twist it a little and try and get a different little orientation on that portal vein. Like right there is better but not perfect. But you would, yeah, okay, so right there, and we're mostly getting